Okay, so we are going to move forward on assessment and treatment of thyroid dysfunction. So we went over those first three objectives yesterday, and what we'll do is we'll cover these two today. And I'm wondering, just by show of hands, did any of you watch that interactive video on that thyroid last night? A few of you did. Hopefully all of you are very familiar with what we talked about in AFMCP, therefore. What I want to do is see if this other clicker works better. Maybe a little better. So I just want to remind us of this, what we're talking about in evidence-based medicine. And evidence-based medicine is not that double-blind, placebo-controlled study. It's not only RCTs. It's all of the evidence. It's the research evidence. It's patient preferences, and it's our clinical experience. So here from yesterday, after that constellation of signs and symptoms, labs, what you test for, and how you follow up or treat, including diet and lifestyle. Now we want to talk about supplementation and HRT. I'm going to talk about nutrient supplementation first. So foundationally, we did talk about dietary and lifestyle changes, etc. And here's what I want to focus on. The specific nutrients that I certainly alluded to in some of that laboratory, but then some other phytonutrients and medications, and then we'll get to HRT. So these are the key nutrients that I certainly went down the list, and I'm going to give you hopefully some reasons that you would use them, not just test for them. So selenium, zinc, iron, iodine, vitamin D, and vitamin A. So first, let's talk about selenium, and let's talk about why are these so important. Well, what kind of evidence do we have? And we have actually, for selenium in particular, quite a bit of evidence. It's a cofactor, as I said before, in these deiodination enzymes, this D1 in particular, and it's an important cofactor in this antioxidant enzyme or selenoprotein, this glutathione peroxidase, which is also important for thyroid production and as an anti-inflammatory for the thyroid gland, essentially. This is the ratio that I discussed in the webinar I discussed yesterday, and it's been associated with selenium insufficiency. And while we can talk about clinical experience, which I do, and I think we should, this is not an N of 1. There's actually a lot of information on selenium, and I'm going to go through it very quickly because I do want to give you some idea of these dueling meta-analyses. So, as I said, now there's a number of studies that suggest selenium intake is correlated with higher or lower antibody levels, right there. And so many people are deficient in selenium, and or at least insufficient. And the question is why? Well, I think there's a couple of reasons. It's not in some of the food we eat, and this is a stylized map, if you can see, of selenium distribution in the U.S. And there are many parts of the U.S. where the soil is insufficient. That doesn't mean you should not be thinking about eating locally. I think that's a very important attribute. But this is telling us that we have a problem in many of the foods that are grown, at least in the United States. There is another reason, or this is on, I guess, on a part of that reason. Some of the soils are naturally deficient in selenium, but we have a fairly large topsoil erosion problem, at least in the United States. So even if you eat well, you might have a selenium insufficiency or deficiency, or a host of other mineral deficiencies. So in some areas, topsoil is 50% eroded. This is just a map again of why are there so many mineral deficiencies? Well, topsoil erosion can be one of those reasons. Here is just another map of looking at selenium, which I showed you, and here's iodine deficient soil. So in the United States, again, what we could talk about, there are world maps showing these same kinds of things. There's a lot of deficiencies in the soils in which we grow our foods, so therefore you're going to have insufficient, even if you're eating organic whole foods, you may have insufficiencies as well. I mentioned nutrient deficiencies yesterday, and this is a little bit older. This is 2004, a little bit older data than some of what I said off the cuff yesterday. But these show some striking deficiencies in the RDAs, and we just don't eat very well. Who knew? So if you look at vitamin A and vitamin D, you can see there that they're both 50% below. Not necessarily what's optimal, but what the RDAs are. And then just as another, while magnesium is not that important to thyroid function, magnesium is probably the most common single nutrient that I prescribe, because there's, at least in this, shows a 43% actual intake compared to what we should be getting. So there's a lot of insufficiencies and deficiencies, and there are many studies in the area of selenium, and so we have a number of meta-analyses, and there are positive meta-analyses. This one was a positive meta-analysis, and this is in 2010, and then, as I mentioned, we have these dueling meta-analyses, and this was a meta-analysis done in the Cochrane database, done in 2013, and they said, as you can read, supplementation in people with Hashimoto's thyroiditis is incomplete and not reliable to inform in clinical decision making. But we have then another meta-analysis in 2014 that said essentially not so fast, and both antibodies, thyroglobulin and thyroid peroxidase, both dropped with selenium supplementation. And I think the important clinical point here is what I show below here, is that it takes a while. So you have to have some patience with selenium supplementation. If you're supplementing 200 micrograms, you want to make sure that you do that continuously, or have your patients do that continuously, and generally in some sort of supplement, for 6 to 12 months. So you need to be patient to see those antibodies levels go down, but you will see them go down in general. And this is the most recent 2016 meta-analysis that also gave a positive review on the use of selenium. So while there certainly is not unanimity in the field, I'm not sure if there's any field where there's unanimity, but given the low toxicity of 200 to 400 micrograms of selenium, I supplement regularly. And just another note, this particular meta-analysis noted that selenomethionine was more effective than sodium selenate. And you'll see, again, you have to sometimes dive into the literature to see what form of what mineral you want to use. And in this case, I think we should be using selenomethionine, and that's what I use. So selenium and now zinc. Zinc can help to normalize. There's this ratio again. The ratio is not here, it's on another slide, but it can normalize free T3 and it can decrease reverse T3, and this is probably the result of zinc as a cofactor for the thyroid receptors. And these are, as you'll see on some hidden slides, these are a little older studies, but I think they're still very germane, and we heard Dr. Evans talk about some of the funding for some studies that seem perhaps they shouldn't be funded. Perhaps we should be funding more of these kinds of studies, but you can still look at some older studies and look at zinc in this case, and I think that you'll find some good evidence for that. And here you can see trials in which they used minerals together, and then you see this ratio again, this low T3, T4 ratio may be related to impaired zinc and or selenium status. I think there's, well, that's an important point, that this ratio, this T3, T4 ratio, is being used in the literature. And I think the other important point is that using these minerals, these two minerals, or using these nutrients together, likely they have an additive effect. They may have a synergistic effect. But I think it's more of a practical way to apply and a practical way to do studies. It's more real-world trials. This is an animal study, but I think it's suggestive that you should use, again, zinc and selenium together. We see a modulatory effect on heavy metals, in this case showing cadmium and improvements when you take selenium and zinc together. I did show, actually it was a hidden slide yesterday, on some NHANES data on mercury, and that there are higher levels of mercury in the blood that are associated with increased TPO antibodies. And so I think that, again, well, I am extrapolating here. This is a cadmium study. This is an animal study. There are human studies in which elevated mercury is associated with elevated TPO antibodies. I think that heavy metals or toxic elements can be ameliorated in some ways by nutritional supplementation. So this is what I'm talking about here. And I would add that we've just added a couple of toolkit items. One is on selenium. Does anybody know and the other is on iodine, which I'll talk about later, but you're all familiar with the food that has the highest amount of selenium? Brazil nuts. Yeah, Brazil nuts. So you can just have, in this case, if somebody is really into Brazil nuts and they eat one every day, they're probably going to get 200 micrograms of selenium. So iron, I alluded to iron a few times yesterday. Iron is particularly important nutrient in deficiency in overall health, but certainly thyroid health in particular. You can see there's more women who have subclinical hypothyroidism who are iron deficient compared to this control group in that study. Iron sufficiency improves the production of thyroid hormones because it's a cofactor of thyroid peroxidase, and so it also seems to indirectly improve the efficacy of iodine, and that's because if you look here, iron is that cofactor for thyroid peroxidase, and thyroid peroxidase pulls iodine into the cell. So you need iron to make that enzyme. If you're not making enough of that enzyme, you're not pulling iodine into the cell. Iron deficiency in inverse relationship to reverse T3. So a significant decrease in reverse T3 and a significant increase in total T4 and total T3 in that particular study. So iron, again, is something that I regularly assess for in a CBC and a ferritin, and I think particularly in women, it's often low, and that often can be associated with low thyroid function for the reasons that I've mentioned, mechanisms that I've mentioned. So we come to iodine now, and iodine is another mineral that is very important for thyroid function, but as I talk about here, it's kind of the Goldilocks controversy. It's not too little and not too much. You have to have iodine just right. And iodine is, as I say here, a double-edged sword. So iodine's both low and high. Diets both low and high in iodine are associated with hypothyroidism. And so high intake of iodine increases the risk of Hashimoto's. There is we can talk about this more in the Q&A. There is a segment of the integrative medicine community that is very keen to supplement with very high doses of iodine from 25 to 25 to 50 milligrams, which is huge doses of iodine, and they base this on an iodine load test that really has not been compared to what are the standards of iodine understanding in the body. So I think that I'm not counted as one of those clinicians that supplements with very high levels because, as I'll show you, high levels are associated in susceptible individuals to much increased risk for Hashimoto's. So, having said that, let's look at the deficiencies first. And iodine deficiency is a real issue in some vegans and vegetarians, and certainly in other populations as well, as this slide suggests, as you can see at the top. And then I want you to look at the deficiency number. They, according to this study and according to the World Health Organization, they look at iodine excretion value below 100 micrograms per liter, and that's what they're looking at in a 24-hour. That's what they've also looked at in a spot urine. I use, as I mentioned yesterday, a spot urine because 24 hours is so difficult to have a patient collect, and while it's not perfect, it is pretty well correlated. Again, my lab has a reference range that goes from 15 to, I think, 716. And so this is, again, a problem with reference ranges when you look at something like that. So I use this World Health Organization cutoff, as I'll talk about a little bit more. World Health Organization is good enough for me. Just a note that exercise, so vigorous exercise for long periods of time, can impact iodine. This is not to say a warning about vigorous exercise, just a clue if you have long-distance runners or somebody who gets vigorous exercise. Let's look at excess. So both low and high iodine intake levels associate with increased occurrence of disease. As I said, low is often associated with goiter. High iodine can be associated with Hashimoto's. What this study, or a couple of studies, are really suggesting is that in vulnerable patients, you can get even modestly elevated amounts of iodine over 500 to 1,000 micrograms can result in autoimmune thyroiditis. I think that those are, again, susceptible individuals. There are many individuals that can do just fine with higher amounts of iodine, but we have to, there's a balance here. And as I'll show here in this study, here's this Denmark epidemiological study, and this is a recent study in 2014, and what they showed is that iodine supplementation resulted in increased risk for Hashimoto's, and so it's a double-edged sword, because why are they supplementing? Because many people are deficient, so you want to strike a balance there. I'm not opposed to supplementation, but I think that there are going to be some individuals that eat in supplemented groups that are going to, it's going to be problematic, but there's many individuals, and that's what, preventive measures is looking at the larger groups. And so we have to individualize this to our patients. Here is where I derive my cutoffs from. This is when I'm looking at urinary iodine, and I like to be between 100 and 300 micrograms per liter. Even so, what they say above 300 micrograms per liter resulted in improved, or less than, resulted in improved thyroid function with decreased TSH and increased T4. So when I do a spot urinary iodine, I do it actually a fasting, which they don't call for, but I just think it makes it more consistent. So I do a first morning fasting urinary iodine, a spot urinary iodine, and I want to see that between 100 and 300. Often, I would say more often than not, I will see it low, and then I'll supplement with anywhere between 250 to 500, 750 micrograms in various supplements that I use. Or certainly, we also have an iodine a toolkit item, so you can supplement. It's basically seafood, and that's why vegetarians are often deficient. It's seafood or sea vegetables that are higher in iodine. So while many individuals are deficient, many supplements have iodine, and perhaps too much. This is a study that showed among 25 brands that contained iodine derived from kelp, 13 brands had greater than 50% discrepancy between the measured and labeled values. So I think this is another reason that we need to be looking at competent vendors, who all of those in our commercial exhibitors are, I believe, and making sure that they label iodine and making sure that they know what's in the bottle. And I think many times there are many vendors who, as this study showed, are not testing it, or they're putting kelp in there and they don't really know how much is in. So I like to go with vendors that have potassium iodide in there and labeled as potassium iodide. This is, of course, the American Thyroid Association recommends against ingestion of iodine or kelp greater than 500 micrograms, except for certain individuals, and I think that's prudent. I think you should be testing for iodine. Again, this idea of nutritional synergies is important. They really are part of a team, if you will, and I think that taking them alone at supraphysiologic doses, when a team approach can often accomplish things at a much more at lower levels. So we saw zinc and selenium before. I talked about iron and iodine. Here we see iodine and selenium showing some nutritional synergies. And here we see, what are we looking at here? It's the same study, nutritional synergies, and so their conclusion, iron and selenium deficiency found in the serum of children with goiter in spite of their treatment with iodine and T4 may be additional factors influencing the effectiveness of treatment. So again, what I'm trying to point out is, well, if you're giving iodine, you may need to give iron because of the mechanisms that I just talked about. Selenium is important again in a number of those enzymes that we talked about. So giving them as a team, I think, is important, and making sure you know what is low or what is high, or supplementing at lower levels that I think are often very safe. So moving on to vitamins. Vitamin A deficiency is, as we talked about, or as I talked about yesterday, is implicated in thyroid dysfunction. So why is vitamin A so important? Well, various studies show this impairs the synthesis and has an effect on that ratio. And why is this more prevalent than we think? Well, first, I showed you that nutritional data and the estimated average requirements. But second, I think that many people have some insufficiencies because of mild absorption disorders and some liver disorders. So I think those are important reasons in that conversion. So why specifically is vitamin A important to thyroid function? Well, I mentioned again some of this. It's important for that T4 to T3 conversion. Note that they turn that ratio around here. They have a T4 to T3 ratio. So some people use this T3 to T4. Some people use T4 to T3. So they're essentially saying the same thing as I said. So there are also other gene polymorphisms, if you will. There are actually some gene polymorphisms that I think I hit a slide for vitamin A, and those gene polymorphisms are very prevalent, and they show that there may be 25% of the population have these a couple of gene polymorphisms for vitamin A, and those gene polymorphisms decrease that conversion of beta-carotene to vitamin A about 50%. So there's a lot of people that have significant polymorphisms that can decrease that conversion. Additionally, as I try to just kind of flipping that around, if you have low T3, then you're going to have a decrease in that conversion to begin with. So there's two ways that you're going to have problems with getting vitamin A into your system right there, or getting vitamin A working right there. This is another vitamin, obviously vitamin D, which we talk about a lot. There are good associations with vitamin D being lower, and also good associations, as this talks about, with vitamin D, low vitamin D associated with Hashimoto's, and those low vitamin D levels being associated with this gene polymorphism, which is this VDR polymorphism, this VDR SNP. So we know that vitamin D is good for just about everything. Certainly, specifically when we look at autoimmune thyroid disease, we can see some suggestions that vitamin D is important. This, I think, is an important slide to note, and what I have been, and I think Filomena was emphasizing yesterday as well, is that even within normal ranges, that's not necessarily optimal. And this is a study that essentially is proving that in this case. So they took 34 women with Hashimoto's who had normal vitamin D status of 30 nanograms per milliliter. And that, for some labs, their normals start at 30. Some labs, their normals start at 20. But the lab I use, my normals start at 30. 30 is not necessarily optimal, so they give them a half of them of vitamin D at a very modest dose of 2,000, and they showed that the titers of antibodies were inversely correlated with those vitamin D levels. So in this case, giving some small amounts or modest amounts of vitamin D lowered those titers for those antibodies, suggesting that 30 nanograms per milliliter is not good, at least in these individuals. And there are many, many other studies that show that 30 nanograms per milliliter in vitamin D is not necessarily optimal. So what I generally shoot for across the board is really 50 to 80 nanograms per milliliter. I have not seen any data that shows any kind of toxicity at 80 or even up to 100. So where toxicity long-term can occur is 100 or greater. So I think we're very safe at 50 to 80, and I think that, again, looking at all of the literature, we should be shooting for higher levels of vitamin D. Why are we low in vitamin D? Well, many of us live below or above the 37th parallel, at least in the United States. And so for a good part of the year, you're just not getting enough vitamin D because we're not getting enough sunlight. So latitude, as I show at the bottom, is important. Indoor living, in terms of just not getting out enough. Skin pigment, obviously the darker our skin pigment, the less absorption we have. Sunscreen use, we lather all that stuff on. And then I think something that we maybe don't think about as enough is, as we get older, aging reduces our ability to absorb vitamin D. So there are a number of reasons why vitamin D may be low and why we should test. So from a supplementation standpoint, here's what I feel I'm very comfortable with giving this without actually doing any testing. As I mentioned yesterday, so selenium, 200 to 400 micrograms, zinc, 15 to 30 milligrams, vitamin D, 2,000 IUs, I'm very comfortable with that. Vitamin A, I'm very comfortable with 2,000 IUs, even in below 2,000 IUs in premenopausal women. I certainly want to know if they're thinking about getting pregnant, but I think 2,000 IUs below that is fine. Iodine at 150 micrograms without testing, and iron in a menstruating woman at the RDA. So generally you can get that in 1 to 2 supplements. And then here, generally, what I referred to yesterday, I don't think I had this slide, was this is what I test for regularly, and these are the levels that I look for. That 50 to 100 I talked about in ferritin, that 100 to 300 I talked about with iodine in that spot urine, and that 50 to 80 nanograms per milliliter if I'm thinking of supplementing more than 2,000 IUs. So when I'm thinking about supplementing more, then I definitely want to test. And I often want to test because I want to make sure they're not getting too much, particularly of iodine as well. This one I think is a little bit out of order, but what I'm going back to is the laboratory for this woman, Jill, that I put a number of slides in your slide deck here. And this was what we talked about before. So this is a review of this woman, Jill. So she had a normal CBC, a TSH of 4.3. She had a low T3, T4 ratio and elevated antibodies. And so we assessed her yesterday with autoimmune thyroiditis and all of these signs and symptoms. And then we got to, so what were we going to do with her? So based upon that nutritional evaluation that I just told you, in this particular case, I didn't use anything but supplementing with nutrients. We didn't actually change her diet. We didn't change her medications at all. So I put her on a supplement with 300 micrograms of selenium, 150 micrograms of iodine, zinc, vitamin A, and it had vitamin D and B3, B2, etc. She was on her current dose of Thyroid, continued on her other supplements, no dietary changes. So in her case, after 2 and 4 weeks, that was really what appeared to be all she needed. So she felt warmer symptomatically, she was doing better, constipation improved, skin wasn't as dry, she felt more energetic, and her fatigue had improved at 4 weeks. And then at 3-month follow-up, her energy was improved, she was not as cold, tolerating air-conditioned buildings, she had new hair growth, her cognitive issues were improved. She also had done her basal body temperature, and she thought that was important, and that had actually averaged 98.8. And she didn't have any problems with insomnia, no constipation. Her skin wasn't dry. She felt more even. She did continue, in this case, to have hot flushes, night sweats. And so when we did a follow-up laboratory at 3 months, we saw significant clinical improvement, or I should say we saw significant subjective improvement, and then we saw significant laboratory improvement. Her TSH went down to what I would say was a more optimal level. Her free T4 stayed about the same, but her free T3 jumped significantly, secondary to what I would suggest was better conversion because of that selenium and zinc, very likely. So that ratio that was low before was now normalized, and her antibody levels at 3 months had gone down, which I thought was significant. So I want to stress that there was no change in medications and not even a change in diet. So sometimes this is all that's needed, and certainly this is kind of foundational and fundamental even when you add hormone replacement therapy, which I'm of course going to talk about. Even when you add that, it makes everything work better. So you don't want to just be thinking about, that's why we spent the first hour and a half talking about diet, lifestyle, nutrient supplementation. You don't clearly want to forget that. That's all foundational and fundamental. In this patient, I was using supplements from a reputable manufacturer, one that's actually in this exhibit hall, so I was pretty confident that what was in the supplement was in the supplement. But as this study that was done a few years ago suggested, we don't always know what's in these supplements because they can be spiked with various things. So of the 10 supplements that they tested, 10 popular thyroid supplements, 5 had T3 levels of greater than 10 micrograms per day at their recommended dose, and 4 delivered a significant amount, or certainly what I would say would be a clinically significant amount of T4. So this is another reminder of buyer beware, and we have to help our patients and help ourselves by making sure that if we don't carry supplements in our offices, that we are making sure that patients get. There are plenty of good quality supplements in the consumer brands. So we should be going to them, but we should also be going to these manufacturers that are out here. There's a lot of online ways that you can do that. So I think it's very important that we pay attention to the quality of these supplements and knowing what's in them. So with that nutrient supplementation, before I turn to hormone replacement, I just want to talk about a couple of other one medication and one botanical that I think are important to be in your toolkit. And from a thyroid perspective, I certainly use a lot of phytonutrients, a lot of botanicals in my practice. From a thyroid perspective, I haven't found, aside from the nutrients that I've mentioned, a whole lot of usefulness of a variety of botanicals, etc. And so I wanted to mention these two, which I thought were important for you at least to put in your toolkit. One is called Nigella sativa, and it goes by the name of black cumin for reasons that are unclear to me because it's not really cumin at all. It is a completely different herb. There's other common names. It goes by names of black caraway, onion seed, what else? Black seed, I think. So, but black cumin is a common name. So it's actually been used for quite a number of years in a lot of inflammatory and autoimmune conditions. And what is interesting there are a number of studies in animal studies that have shown some effects on the thyroid. This study, which was done just about 2 years ago or a year and a half ago, was the first study that I've seen, and I think the first study that's been published on a human study in autoimmune thyroiditis. There's many other human studies for Nigella, but on autoimmune thyroiditis. And what they did here, this was a small but double-blind, placebo-controlled study that they showed positive results in autoimmune thyroiditis. So they split up the group. They gave them 1 gram of Nigella twice a day versus placebo. And then from this data from the trial, and there were no changes in the placebo, but in the Nigella group, the TSH dropped by over 2, the T3 increased by 0.14, and the antibody levels dropped in 8 weeks by about 146 points. So those were all statistically significant in this small group. And of course, this is TPO antibodies, which are the main antibody in most autoimmune thyroiditis. So to see it go lower that quickly is fairly impressive, and it shows, I think, that it's likely that it's having some effect on the inflammatory process. And so how does this work? Well, Nigella contains something called thymoquinone, and that thymoquinone is a phytonutrient, and previous studies have shown that it decreases TSH in animal studies, increases T3, has effects on insulin resistance, inflammation, etc., so that it also decreases in some inflammatory markers in terms of cyclooxygenase and COX-2 enzymes, etc. So it seems to have anti-inflammatory effects and seems to have some specific effects on the thyroid. So since this study came out a couple of years ago, I've started using Nigella in selected patients. I don't use it alone. I use it in combination with other things, but I think this, in my clinical experience, suggests it seems to be a very safe herb in all of the studies that I've seen. So that's one herb and that I think you should think about. These are additional references on Nigella in animal studies. These are just the animal studies for thyroid that I put here. But I think it's very safe and it's worth thinking about in AIT. The second thing I want to talk about before we talk about hormones is low-dose naltrexone. How many of you use low-dose naltrexone? So I see maybe half or a third of you do, at least here. So low-dose naltrexone has an interesting history. Of course, naltrexone in the 1980s, it's an opiate antagonist medication, was actually was developed in the 1960s and given approval as naltrexone in the 1980s for the treatment of opioid addiction at about 50 milligrams. Then in the 1990s, as you can see here, researchers began to discover that lower doses of naltrexone at 1 to 4 or 4.5 milligrams had an antagonistic effect for a shorter duration, 4 to 6 hours, as I talk about here. And then there's a rebound effect of increasing production of endogenous opioids, endorphins, enkephalins. And so all of these substances seem to activate the opioid receptor. And so then in the 1990s and then in the 2000s, there started to be a number of trials, as I show here, multiple sclerosis, Crohn's disease, so some autoimmune conditions, fibromyalgia, cancer, chronic fatigue syndrome, various pain syndromes that had some positive effects on using this low-dose naltrexone. Here, again, I've gone over briefly already these mechanisms of action in terms of how it, if you will, this rebound effect and other likely mechanisms of action, and it inhibits pro-inflammatory cytokines. So there are a number of mechanisms, and it blocks the opioid receptors in the GI tract. And as I took out a quote here, the body's cells respond to these peptide neurotransmitters by initiating various biochemical and cellular changes that inhibit cell growth, promote healing, and reduce inflammation, thereby helping restore homeostasis. So it's from the mechanisms, it can have a wide array of potential therapeutic interventions. So it has been used in autoimmune, a number of autoimmune conditions, as I showed, IBD, Crohn's disease, multiple sclerosis. The theory is that there are similar mechanisms of action over many different autoimmune conditions. However, as far as I've seen, there are no published studies on low-dose naltrexone in autoimmune thyroiditis. Here are, just to give you a sense of just the human trials in autoimmune disease, there are quite a few, as you can see there. So there is quite a bit of biologic plausibility in low-dose naltrexone in autoimmune diseases. And then, so there's now been a number of discussions about low-dose naltrexone in autoimmune thyroiditis. So these are the proposed mechanisms of action in autoimmune thyroiditis. We had at our annual conference two clinicians. One was a gastroenterologist named Dr. Whitfield. His name will come up, and then Dr. Cottel, who both, and she's a family physician, and Dr. Wakefield, I think. It's not the Wakefield you may be thinking of. I have his name wrong. I'll get it right in a second. He's a gastroenterologist, so showed some very interesting slides and case studies in IBD. But they also talked about autoimmune thyroiditis in terms of what are the potential mechanisms of action here. And this is what we see. This is what they suggested. This is what other people have suggested as well. So the treatment with low-dose naltrexone is really the same treatment as with any autoimmune disease. It's low dose. You start at 0.5. You get this from a compounding pharmacist. Start at 0.5 to 1.5 milligrams a day. You increase up to 3 to 4.5. I use 1.5 milligram capsules, and I increase over the course of 2 to 4 weeks, or you can go slower. And you want to observe over that period of time, or I generally test at 6 to 8 weeks to see if you need to change thyroid dose requirements. Weinstock was his name, who's at the bottom of the slide here, who's published some studies. This was looking at the potential side effects. The only side effects, while there are a number of potential side effects, it seems very safe. Particularly, you take somebody, they have a side effect, you take them off, those side effects go away. The ones that I have seen are insomnia and some kind of night dreams that are vivid dreams, let's say. So those are the only side effects I've seen. There is now, generally, most people use low-dose naltrexone in the evening because of some of these proposed mechanisms of action. If you have some side effects using it in the evening, I would suggest you use it in the morning because there's other mechanisms of action. So it's got a variety of action. It's just been traditionally used in the evening. I'm not sure if that's absolutely necessary. So that's the second, if you will. Certainly we want to look at diet, lifestyle factors, nutrient supplementation, and then I look at Nagella and LDN that I've started to incorporate certainly in the past couple of years, which brings us to the conscious use of HRT in thyroid dysfunction. So that's what I want to spend the next 45 minutes on. And what I want to talk about is what to prescribe and when to prescribe it. So to do that, I want to first have you get out your cell phones here, and hopefully in live streaming land you've already looked at these questions, and we'll go to the first question here because I want to get some ideas of what you are doing. So the question is, how many of you prescribe T4 hormone replacement only? So a small number prescribe T3 and T4 hormone replacement. Maybe a third of you prescribe a standardized glandular desiccated thyroid. Maybe about 16% prescribe synthetic and porcine glandular. Of course, you can answer more than one. And then there's quite a few of you that don't use any thyroid hormone replacement at all. Now, I think that some of us don't necessarily, it's not in our scope of practice, but hopefully after I go through this, you may be thinking, if you haven't used it at this point, that you may want to think about using hormone replacement in selected individuals, or as you'll see, I'm going to talk about using combinations, and I am generally more comfortable, or I think that there is a subset of individuals who do better on combination hormone replacement. So let's go to the next one. So which of the following is most likely to suggest a trial of thyroid hormone replacement? So the first, elevated free T3, free T4. So you should be answering that, but there's elevated free T3, free T4 is a good thing. So that really shouldn't suggest hormone replacement. Low urinary iodine. Well, low urinary iodine is not a good thing, but I'm not sure it suggests hormone replacement. It might suggest iodine replacement. TPO antibodies within normal limits and a TSH below 5. Potentially, in that case, it wouldn't be the first thing I would do, but a low total T3 to reverse T3 under 6, and that's most of you would pick that as what would suggest a trial, in addition to the other things, hopefully, that you do. And so we have one other question, I believe. Which of the following do you think are correct regarding thyroid hormone replacement? So the first one, some patients demonstrate depression and anxiety with T4 monotherapy in spite of normal TSH levels. So that is, actually I'll talk about that, and there's some data to support that. In some patients, T4 monotherapy may not restore T3 levels in serum and target tissues. That I've alluded to that. I'll talk about that more. Many of you are agreeing with that. The third, excessive T3 can increase TSH, causing side effects. Well, so this is not, that excessive T3 can not increase TSH, it would decrease TSH, so that's not really correct. It can cause side effects for sure. TSH can be utilized as sole criteria for assessing suboptimal thyroid function. So all of you have either read yourself, have watched some of our previous information, or heard what I alluded to, and so none of you are picking that. So let's discuss then the big issues in thyroid hormone. And that is, do you prescribe T4 and T3, or just T3 or just T4, so combination or monotherapy? So the first, specifically, here are your choices, of course. There's T4 therapy, there's T3 therapy, and then there's this combination therapy. The big question again is, when do you use combination therapy? And that combination can be individually delivered, synthetic T4 or T3, compounded T4 and T3 together, or thyroid porcine glandular, and that's compounded together. So we discussed this conversion yesterday, and the issue of T4 and T3 combination therapy is really still the subject of a lot of debate. There's been studies, there's animal studies going back, fairly famous rat studies going back into the 1990s, where they showed that only combined therapy of T4 and T3 resulted in ensuring tissue saturation in animals, in rats that didn't have a thyroid gland. And then there was, in 2006, there was a meta-analysis that suggested that there was no improved use of combination therapy. But two factors, debate has continued, and two factors have really contributed to this. First, there is a significant body of literature that not all patients are satisfied with T4. These are large community-based trials, these three trials that have been done in the mid-2000s that suggested that there was a subset of individuals that were on T4 treated with normal TSH, and they weren't happy. Their symptoms, after you controlled for everything else, their symptoms were not controlled, and they did not feel sufficiently satisfied with how they were feeling. So secondly, evidence has been accumulating that exists these tissue-specific regulation of thyroid hormones, as I talked about yesterday. And so intracellularly, this D2 that I alluded to yesterday, T3 content in the brain is predominantly derived from intracellular deiodinization of T4 to T3 by this type 2 deiodinase D2, and not from serum D3. Therefore, just looking at serum hormones or looking at the levels in the serum are not necessarily enough for us. So if one assumes that T4 monotherapy may not necessarily fully restore T3 content of target tissues, it's biologically plausible to suppose that there can be complaints and benefits from combination therapy. And then the last thing I'll say is that understanding that giving more T4 can often inhibit this D2 deiodinase enzyme, so that doesn't necessarily solve the problem. So with that, is there a case for combination therapy? And as you can surmise from what I've said, my answer is yes. Is the evidence universal? Well, no, it's not universal, but there is sufficient evidence to make one evaluate the potential. And there have been a number of attempts, since this meta-analysis in 2006, and really over the past 14 years or so, that show that or that look at and show that impaired psychological well-being and depression or anxiety have been shown to not improve some patients, some hypothyroid patients on monotherapy despite normal TSH levels. And this is the evidence. This is a 2014 report that showed these are the largest studies. In 7 of those 11 studies, TSH was in the normal range, and they had increased symptoms of depression or anxiety in this case compared to controls. And the second point in making for combination therapies, or there's this reports in the literature of patient preferences for combination. So I talked about, well, patients aren't satisfied with T4, but when they have when they've been randomized and blinded to whether they were on T3 or T4, they generally, when asked, they ask for that combination. And this is the evidence that most studies, all but one, had a clear patient preference for combination therapy. And again, these patients were blinded. So there is evidence for combination therapy. So thus the 2 points I made here do suggest the possibility of a subset of patients. I'm not saying that every patient needs to be on combination therapy, but a subset from this combination. And so, why is that? Well, persistent symptoms might be explained by the inability of T4 to restore T3 levels in serum and all target tissues. Here's that evidence, that kind of biological plausibility. I'm not going to go through this, but you can see it that T4 within the cells is not necessarily adequate. And then, as with everything, there are other variables. So there are variables in these deiodinase SNPs, in these polymorphisms for these enzymes, are likely part of that variable. And common variants in deiodinase 2 gene may predict poorer psychological well-being on T3 monotherapy and improve response to T4, T3 therapy. What this and other papers suggest is that patients who continue to be symptomatic on T4 therapy, perhaps a clue is this gene polymorphism. I don't think that's everything, that it's just in the genes, because hopefully I gave you enough information that there are other lifestyle factors that can affect it. But I think that these do give us good clues. And here just is a schematic that shows the D2 intracellularly. I talked about the brain. It's in the heart, it's in the skeletal muscles, intracellularly in brown fat tissue as well. So this all suggests that there can be a biological bottleneck, if you will, and I don't want to overemphasize the SNP part of it, but it's clearly part of the puzzle and does add to that biological plausibility. This is evidence that I showed in AFMCP and in that webinar. This is a great study that really showed that nearly a third of individuals who were on T4 therapy they didn't have a thyroid, and therefore they were only getting T4. Nearly a third of them did not reach that ratio that I talked about. So what is that? What is that number of individuals who who perhaps need combination therapy? I'm not sure what it is. It's more than 0. It's less than 100. I think it's somewhere around a third. It may be higher. It's more that come to me because I'm not seeing in primary care. But I think there's a significant number of individuals. There's other issues with that reverse T3, etc. And I've been talking about these deiodinases exclusively, but truth be told, there are many genes here I'm showing you. And many polymorphisms in which we just don't know the individual effects. And so with this kind of information, I find it implausible to say that some patients don't have a problem with some conversions of T4 to T3. So therefore, while levothyroxine remains standard of care, combination treatment might be offered in selected patients. The ETA, as I mentioned, the European Thyroid Association, now suggests it's experimental therapy. The ATA, American Thyroid Association, in 2004 now calls it not innovative therapy. So some of these societies are also coming around. And therefore, T4 remains the conventional treatment modality. Combination treatment might be offered to selected patients. One side note here is that I just read recently that, at least in England, the cost of T4, of 20 micrograms of T4, because so many patients are looking for combination therapy and many more clinicians are prescribing combination therapy, T4 went from less than £1 for a pill to like 9 pounds per pill. And now there's There's legislation in 2017 in the state of Maryland to forbid that, and it's a generic product, it's off patent, to forbid that kind of price gouging. So there is, people will be people. So what is the case against combination therapy? And there are some important points to be made here. First point, careful dosing. I think we have to be careful on that. The second point is that we do need to individualize it. I'm very careful with older adults that I'm much less likely to offer combination therapy or to lower TSH too far, because I think there's a likelihood that they don't do as well, and there may be some biological needs to have a higher TSH as we age. So I'm very careful about that. And then the big thing is this third point: excessive T3 can lead to suppression of TSH and therefore a host of side effects. And you've heard, I've certainly heard patients come back in, and when their TSH is a little lower, their primary care physician is saying they're going to get osteoporosis and going to die of a heart attack. So let's look at that a little bit to get a clearer picture. What are we talking about in terms of excessive risk? So what are we talking about? TSH suppression, because we don't want to, I'm not throwing TSH out. I always test for TSH, but TSH is you want to test it in combination, and how low is too low. This is an older study that looked at long-term therapy of an average of 8 years, and they showed that there was, with a suppressed TSH, no lower bone mineral density. So that was an older study. These are two large studies done in Europe in about 10 years ago, 2008, 2009. One called the Hunt-2 study of 6,000 women, the other called the Trumpsa study of almost 2,000 men and women, and they showed no differences with TSH within the normal range. So lower TSHs, there's no problem with going to a lower TSH within the normal range. Both of these studies found. So 0.5, if somebody, if you have a TSH that was 3 and now it's 0.7 or 0.5, you should not be concerned at all, no matter what your colleagues say. But in addition to that, this is the most recent and largest long-term study I've seen, again, looking at TSH suppression. And this was a study done in Thyroid, Scotland. 17,000 individuals on T4 replacement. They categorized these patients into 4 groups, and they looked for over 8 years for dysrhythmias, fractures, and cardiovascular disease. And they categorized them as suppressed TSH, which was below 0.03. Low TSH was between 0.4 and 0.04. That's low. Many of us would consider that suppressed. They called that low TSH. And then normal TSH, 0.4 to 4.0. That's what their normal range is. And then an elevated TSH above 0.4. And what they found there was essentially patients with a high or suppressed below 0.03 or above 4 had increased risk of cardiovascular disease, arrhythmias, and fractures. So we're talking about osteoporosis, osteoporotic risk here. But patients with a low or unsuppressed, so anywhere from 4 to 0.04, did not have any increased risk of any of those things. So I think that, again, we're looking at below what the labs say is the normal reference range. We're talking about 0.04, which is below the normal reference range, which is 0.4. I generally, long-term, I am fine. Short-term being 3 to 6 to 9 months, with actually being at 0.01 or, 0.04 or 0.05. I try to get people a little bit higher if I'm just looking at TSH of 0.1, but I'm not concerned, certainly for the short term, of being even lower than that, or for the long term of being somewhere in that range. So I think that this gives me at least more confidence in looking at TSH and looking at those perceived risks that we have. So another look at, this is actually the same study, the same group of individuals in Tayside. They took those individuals and compared those ones who were just on leothyronine 400 to a group that was on levothyroxine, and for patients taking long-term levothyroxine, there was no additional risk of atrial fibrillation, cardiovascular disease, or fracture. So that's just a sidelight. Same study that was just published recently. Same group that was just published recently. Okay, so now hopefully I've convinced you that combination therapy is useful and that HRT in individuals that don't necessarily have classic hypothyroid or perhaps are subclinical hypothyroid may be candidates for HRT. And so what about this question about synthetic versus desiccated porcine glandulars? So a natural desiccated thyroid has been around for the past 100 or so years. It's been approved by the Food and Drug Administration since the 1930s. It's made up to standards of the USP. But since levothyroxine came on the scene, synthetic levothyroxine came on the scene in 1949, it's been denigrated as old-fashioned, if you will. There was a report in the early 50s of a severely undertreated patient with natural desiccated thyroid, and that, again, kind of sealed the deal. And so has been huge marketing issues around Synthroid and levothyroxine. However, right now, for many years, all thyroid hormone manufacturers must follow USP guidelines. And with the new technologies, since the 1980s at least, these natural desiccated thyroid manufacturers, they can now measure the actual amounts of T4 and T3, whereas before they couldn't, they were just measuring iodine. So we know exactly how much is in each tablet. So there's really absolutely no difference in standardization between synthetic and natural forms of thyroid, as long as the manufacturers are doing what they're supposed to be doing. So there is a case for desiccated thyroid preparations. What's that case? Well, it's got a bunch of other things in it. It's got T1 and T2. They may have some biological activity. I suggested that perhaps they don't, but they may. It does have iodine. It has thyroglobulin protein. It has calcitonin. It has some other glandular tissue that may be useful. 1 grain of natural desiccated thyroid has 120 micrograms of iodine, so it has, the adult RDA is 150, so it has a significant amount. It's got a relatively low price. You can't patent that. And there's also, as I've listed here, some research suggests hypothyroid patients may have equal or greater improvements on desiccated thyroid. There's a 2013 study that I showed that showed there was a preference for natural desiccated thyroid. So there is a case to be made for natural desiccated thyroid. What's the case against? Well, it's the same argument for other combinations. That doesn't change. The other argument is that it contains more T3 than our natural human secretions, and therefore it's super physiologic dosages of T3. I suppose there is some biological evidence for that. However, there's also some evidence intracellularly that the proportion of T4 to T3 is closer to 5 to 1. So I'm not so worried about that or think that's such a case against it. There are certainly some groups who have religious or ethical issues, so Hindus and Muslims and some of my friends who are flexitarians. They'll eat what they want to eat when they eat it, but otherwise... I'm not going to name any names or anybody that I went out to dinner with yesterday. But there are certainly some ethical issues, and that's when you want to use a synthetic. And lastly, there's this issue of desiccated glandulars potentiate this autoimmune attack. And the idea is that desiccated thyroid has some antigenicity and it has some decoy effect. And then this perpetuates this autoimmune attack. And while that is certainly, if you go on the internet, you can read all about that. It's an interesting theory. There's no literature to support that at all. There's none that I've ever seen. You can go on the internet and find whatever you want, but there's no literature to support it. In fact, there's some literature that shows, that I've listed down here, it's older literature that shows that it may have some sort of countervailing balance and may act as inducing tolerance. So I don't think there's any good argument that that's a reason you shouldn't use it. So, but pharmaceutical companies really want you to follow that script. This is an older 2013. This is a famous movie star whose name I forgot, but she's, the advertisement was follow the script. So there is huge marketing dollars behind the pharmaceutical companies. As I said, Thyroid, levothyroxine, or Thyroid in particular, is the second most common prescribed pharmaceutical in the United States, at least. So, there's a lot of fear around using combination therapies and not following the script. So when should you prescribe hormone replacement? And then in terms of, I'll talk about, how I prescribe and when I prescribe combination. But I want to kind of take you through this flow chart that we have that hopefully will give you some idea, at least, of how to proceed. And so first, if I'm thinking about thyroid dysfunction, I order, as you can see, and as I've talked about, the appropriate labs of the initial lab workup and then additional labs as indicated. So next, I differentiate if they are or not on thyroid hormone replacement. So if they're not on thyroid hormone replacement, then I want to, with those labs, I want to know if they are antibody negative or antibody positive. That's very important to me, as I will talk about a little bit more. But if they're antibody negative there, then in general, they've come in with signs and symptoms and labs suggestive of thyroid dysfunction, antibody negative, then I'm going to do all of those things from a diet and lifestyle perspective, and nutrient supplementation and even phytonutrient supplementation. If they're no better, then what I'm going to do is I'm going to then think about initiating some kind of thyroid hormone replacement and then consider further evaluation for other things. As I say, they're dysbiosis or various other things, but that's depending upon the patient and this is the general way I would like to proceed if they're antibody negative. Now, if they're already on a thyroid hormone replacement and they're still antibody negative, but they're on thyroid hormone replacement, I'm going to do the same kinds of things. I'm going to not mess around at this point, depending, again, it's all individualized, but depending on that individual, I'm going to try to buff up everything else that we can work on. If they're then no better after 4 to 6 weeks, then that's when I'm going to, in antibody negative individuals, that's when I'm going to consider hormone replacement. Now, if their labs are suggestive of some sort of dysfunction and they're antibody positive, I am much more likely, not absolutely, but much more likely to put them on hormone replacement and put them on some sort of combination, because I think that antibodies clearly are suggestive of an autoimmune attack, and I think that is a more likely condition in which I am not going to get as much improvement without putting them on thyroid hormone replacement. That doesn't mean that all of those other things don't come into play. As I mentioned, I think they are much more effective together, but this is the kind of protocol or kind of flow chart that I follow. So first, to say there's no one way to proceed, but if I choose to start on thyroid hormone replacement, the old adage of start low and go slow, and that's what I do. And here is generally what I do. I generally put individuals on combination. If a patient presents naive to thyroid hormone replacement and they don't have any obstacles to desiccated, that's what I'll start on. I generally start on a combination, and that's because I just feel it's a more practical way to approach it. I don't have to start on T4 and then go to a combination. I'm going to start on a combination. I don't see any downside to starting on a combination if you're starting low. If a patient comes in on T4 monotherapy, which they often do, I generally don't switch them to a desiccated. I generally add a synthetic T3, liothyronine. And I'll talk about that and in terms of how much, but also that's like to like, and I think that's an easier way. And I occasionally use compounded. There are all sorts of compounding pharmacists, and they will talk about so you have an ability to do whatever compounding you want, and also some of this compounding pharmacists will suggest that there is a slower release, which I do believe. I just find it more expensive and generally not necessary. So prescribing thyroid hormone replacement, if they're not on thyroid hormone replacement, I'll often start, as I said, on this desiccated thyroid, a half grain, which is 19 micrograms of T4, 4.5 micrograms of T3, and increase at half grain increments over the course of 1 to 2 weeks. I talk about, with each patient, I talk about taking too much and cutting back, but I want to make sure that before I see them again, they've experimented. So that's when I see them again. I generally see them again without doing labs because I want to see where they are, and then I'll do labs. They're currently on T4 therapy. As I said, I'll often add this liothyronine at 5 micrograms. Liothyronine, if you don't have it compounded, comes in 5 and 20. I think 5 is generally what I use. Sometimes I have them cut very tiny tablets in half. And then I drop that liothyronine on a 1 to 4 ratio, and I generally go up to 10 micrograms BID over 4 to 6 weeks. Usually I do a little bit lower than that. I don't usually need to get up to 20 micrograms of liothyronine. If they're currently on desiccated thyroid, I'll often add liothyronine because I'm looking at that ratio, I want more T3, so then I do the same thing with synthetic T3. So dosing is once or twice daily. Here's where a bit of controversy resides. I find that when you're using this desiccated, probably because the thyroglobulin protein kind of binds and slows down the activity of the breakdown, that using combination desiccated I can use once a day. Levothyroxine is definitely once daily, of course. It has a half-life of about 5 to 7 days. Liothyronine has a half-life of about 24 hours. If I'm using more than 5 micrograms, I generally try to use that twice a day. So morning and afternoon, away from food, always away from food. Porcine, as I say, once daily, and time release, sustained release, I don't use very much, but you can use that once daily. So we already talked about timing and differences in some of the ingredients. Now let's discuss some other differences and how one might compare and contrast, which comes down really in terms of these desiccated products to binders and fillers. The thyroid gland makes about 100 micrograms of T4 a day and maybe 10 to 20 micrograms of T3 a day if you have a properly functioning thyroid. If you don't, obviously it's not making that much, but those are clearly very, very tiny amounts, and that's why you need to make a tablet to have these binders. That's why you have these binders and fillers. And the first ones that were cornstarch, and that could be some allergic reactions to that, undesirable reactions to some of these fillers. There are 3 main brands of these NT. There's Armor, there's Nature-Throid. Nature-Throid is also West-Throid is the same thing, and then there's WP Thyroid. The Armour has a number of binders and fillers that are not quite as hypoallergenic. The Westroid and the Nature Thyroid are much more hypoallergenic. They don't have any gluten or cornstarch or colors or flavors or rice or soy or eggs or fish or shellfish. They're pretty hypoallergenic. If you really want to be really hypoallergenic, you go to the WP Thyroid. All that has is inulin and medium chain triglycerides. I generally don't find I need to use that. The Nature Thyroid is what I use because it has many, many more. It's got like 13 different levels that you can use, going down from 1/8 to actually 4 grains. So that's generally what I use. I certainly use Armour Thyroid sometime as well, but I'll start generally with Nature Thyroid for those reasons. And as I said, the Armour has a couple of other inactive ingredients that some people feel that they have some problems with, and so I generally start with Nature Thyroid. Both Nature Thyroid and Armour have lactose, very, very, very tiny amounts, milligram amounts. We're talking about when you drink a glass of milk, it's like 10,000 to 15,000 milligrams of lactose. They were talking about 3 to 5 milligrams of lactose. I don't think that's going to bother an individual who has some lactose issues. It doesn't have any milk protein, so there should be no allergenicity. But you can think about that in terms of if you want to use something else as well, like the WP Thyroid. So lastly, before I get to a case here, I just want to say, remind us to think about thyroid function before giving a statin. Well, I talked about this yesterday, but what I want to add here is not only may an optimally functioning thyroid obviate the need for a statin, statins go through the same, or thyroid and statins go through the same cytochrome P450, 3A4, and so when you're taking this competition for metabolism from different medications can contribute to an increased adverse effects in terms of these myopathies that a fair number of individuals have with a statin. So you want to be careful about the metabolism of these medications. So I want to now talk about a patient that I did use hormone replacement therapy, and this was a patient who was a 38-year-old female when I saw her. She's about 42 or 43 now, maybe 41 actually, 3 or 4 years ago. So she came in with fatigue, chronic constipation, PMS, insomnia, joint stiffness. She's forgetful. Her issues started when she was 16 or so with irregular periods. She decided to have children at 25, but had a lot of difficulty conceiving, had her first child at 30. She got some severe GI infection. There was no official diagnosis. She was treated with metronidazole at 31. She had her second child at 33. She had a postpartum diagnosis of goiter. Likely, I say, secondary to Hashimoto's. I don't believe she was assessed at that time. So then she was placed on Lukaczer. Sometime later, she was diagnosed with Hashimoto's. She had her third child at 36. The next year, she continued to feel this increasing fatigue. She went to a naturopathic physician, had some IgG testing done, revealed she had IgG testing and she was sensitive gluten, almonds, dairy, and eggs. She went off of all these for a year without any improvement. She went to another ND who found some elevated ANA titers, went to a rheumatologist who examined her, and she said she doesn't have any other autoimmune disease, so essentially she didn't have titers high enough to be treated. So she came to me, she was looking for other options, and she felt that she had gone back and forth with her endocrinologist of, raising the T4 and really not getting much help in that way. Family history is unremarkable. Diet history, for the past year, as I said, no gluten, almond, dairy, or eggs. Essentially, I'd gone off all grains and legumes, high fruits, vegetables, and adequate protein. She said, I believed her. She was OCD, or she said she was OCD. She really did this. And with 3 kids, she's crazy. And so, well, that was the reason, she wasn't getting any improvement. So that's like, do I have to do this? Is this helpful? So the medications, as I said, levothyroxine, she was on vitamin D. She was a slender woman. She had a positive zinc taste test and leukonychia, which is these white spots. Otherwise, the exam was unremarkable. So I'm thinking zinc insufficiency. Well, I didn't test. This is what I did test. TSH, normal. Free T4, low normal. Free T3, kind of normal. Total T3 was low normal. Reverse T3, pretty normal. And she had elevated TPO antibodies, significantly elevated. Urinary iodine in the normal range. She had an elevated HSCRP, and because she had been off of all gluten for a year, I didn't want to do a celiac panel. I didn't think that would be useful, so I did a DQ8, which she was negative, which suggested she would never get celiac disease. That doesn't suggest that she's not sensitive to gluten. And then I measured these ratios, and both of those ratios were low. That free T3, free T4, I want that to be 0.33, so that was marginally low. And this total T3 versus T3 was significantly low. I like that to be above 6. So what did I assess? Autoimmune thyroiditis with certainly symptoms suggestive of low conversion, low thyroid function, of things going to reverse T3 and not to T3, and competitive inhibition of those cellular receptor sites, as I said. So what did I do then? So going back to this flow chart, we had this initial workup. As I've talked about, that was, I did some of that initial workup. She was already on a thyroid hormone replacement. And she was antibody positive. So according to my flow chart, according to what I generally do, and certainly with her, so I'm going to do some of that nutritional support that she hadn't done, and then I'm going to reconfigure at that point her thyroid hormone replacement. So I added a multiple with selenium, with iodine, with zinc. And those levels, I didn't measure selenium, iodine, or zinc. I thought those were perfectly reasonable. I actually did measure serum ferritin. I didn't show that. That was normal, so I just put it, this was just in the multiple, 18 milligrams. And I did measure vitamin D, and that was low at about 22, so I actually increased the vitamin D. I was doing some standard, if you will, in part because of what she had said about her past medical history, about this dysbiosis and this GI infection treated with metronidazole. So I put her on a combination probiotic. I put her on this prebiotic called arabinogalactans that comes from larch. Put her on higher doses of vitamin D, as I said, and I started to have her reintroduce some of these foods that had been eliminated in the past year and assess. I think she was off them. She had a pristine diet, so I wanted her to go back on these things and see if they caused any problems. And then in a stepwise manner, I increased the leothyronine and decreased the thyroxine over the course of about 4 weeks, so to essentially change that ratio. And I saw her back in 5 weeks. Clearly, she was doing better. Her joint pain had improved. Her bowel movements had improved. She had reintroduced eggs and almonds without problems. She was up to 15 micrograms and down to 50 micrograms. She was taking, at that time, the supplements consistently. And then, so we planned to reintroduce grains and legumes and assess and do some follow-up lab in 4 to 6 weeks. So that's what we did. She continued to do well. And then we did this follow-up lab, and her TSH certainly stayed about the same. Her free T4 was 12. Now it actually went down a little bit, which I'm not concerned about. Her free T3 was 3.6. It went up a little bit. Her TPO antibodies they stayed about the same. Her hsCRP had come down, but you can see as I figured out that ratio, and her ratio had improved, and actually her T3, total T3, reverse T3 had also improved later. I didn't do it at that time. So we plan to continue on the current plan, labs in 6 months, discuss further evaluations of antibodies. And so I've seen her now over the past 3 years. She's continued to do well on that level of 50 micrograms and 15 micrograms of T4 and T3 respectively. Her hsCRP has come down and normalized. Her thyroid antibodies have come down marginally. She's been not quite as compliant with some of the supplements. She's very compliant with the T3 and T4, but she is doing very well symptomatically, and from looking at those laboratory values, also doing very well. So what I want to just remind you of is here is how I kind of view what I want to do with an individual who comes in. That's my standard flow chart. So just summarizing here, these are the primary symptoms that certainly raise my index of suspicion. These are the labs, along with symptoms, that would suggest a trial of thyroid hormone replacement, positive antibodies, with those other numbers that I've suggested there. So the goal is to improve symptoms in the context of these normal ratios, and I think we always want to look at that in the context of signs and symptoms. And I wanted to put this slide in here just to remind us all we need to do, if you will, all of these things together, because what this study is essentially saying is that using levothyroxine with selenomethionine improves systematic effects on these women with Hashimoto's thyroiditis. So I want to just for just a couple of minutes, just ask you a couple of questions just to see what kind of responses we get. So the first question is, based upon what I've said, how many of you plan to utilize either these ratios in the workup of a patient that you might suggest? Well, that's good. That means that I've made enough of a stink about those ratios for you to think about them. Let's go to the next question. How many of you plan to begin utilizing combination T4, T3 therapy, either using synthetic or porcine glandular in the treatment of selected patients? So many of you were using combination. Many of you weren't, and this question doesn't ask how many of you really changed from not using anything to using something, but I think that in selected patients, certainly using combination therapy, I think can be very useful and really a good step in treating our patients in an integrative functional medicine manner. So let's go on to, and I'll just finish up with these last couple of slides. So there are cautions with thyroid hormone replacement. There's overdosing. There's medical legal issues. Certainly there's overdosing. I talk about in the AFMCP about looking at different age groups, but there are certainly symptoms that you want to look for in overdosing. There is certainly altered absorption. You really want to, I think in general, while there's some controversy about this, in general, I think taking these thyroid hormones away from food by an hour. Sometimes some people actually take thyroid hormones in the evening and do very well with them, but there are many things such as coffee and soy and calcium that will have an effect on absorption, so you just want to keep away from them. You want to think about medical legal issues. You would definitely want to think about an informed consent. I don't generally get a baseline DEXA or baseline EKG, but you may, depending upon your scope of practice, you may want to think about that. So here's the summary of the clinical approach, and I would say that, you know, if I have 6 to 12 weeks in a patient who is exhibiting signs and symptoms of low thyroid function or Hashimoto's, I'm pretty confident that I can help them symptomatically. I'm not, as we talked about yesterday, I'm not completely confident that I'm going to cure them, but I'm fairly confident. I have a lot of experience, and I'm fairly confident in those patients I'm going to be able to help them if I have 6 to 12 weeks. And I can tell you it's not a placebo effect, because I'm just not that charismatic. So if they're getting better, I'm pretty certain they're getting better from the things that they're doing. So this is the last couple of slides. It's just, this slide is, you know, just suggesting that it's a complex and evolving field. There are a lot of different regulatory mechanisms. The science is not all worked out. What we're clarifying is, you know, it's not black and white, as some of our endocrinology colleagues might suggest. And as I think some of their literature, as I've showed you, also suggests, there are shades of gray in this, and that's why I think we should be looking at, you know, adding more keys to the keychain. And the last thing I'll leave you with is a quote. I love this man. I wish I was, I'm glad I'm living in 2018, but if in a past life, it would have been nice to hang out with this guy. He seemed like a really interesting guy, Dr. William Osler, and he said a lot of really amazing things. He said this in 1907. He said, "But whatever you do, take neither yourselves nor your fellow creatures too seriously. There is tragedy enough in our daily routine, but there is room, too, for a keen sense of the absurdities and incongruities of life. And in the shifting panorama, no one sees better than the doctor the perennial sameness of men's or women's ways." So with that, I thank you, and I'll give it to Dr. Evans.